Gabapentin is one of the most prescribed medications for neuropathy, and it does something real for about 3 out of 10 patients. Here's what nobody tells the other 7. It was never designed to stop your nerves from getting worse. It turns down the volume on the pain signal. That is a very different thing, and it actually explains a lot. I've had this patient hundreds of times in my 35 plus years of practice, with the last several dedicated entirely to patients with peripheral neuropathy. A patient comes in, they're on gabapentin for a year or 2 or sometimes even longer. The relief that was there at the start faded. The doctor says try a higher dose, and they're dealing with more side effects and less control at the same time. Nobody has explained why, and I'm going to give you that explanation today. What gabapentin actually is designed to do, why it stops working for most people, and what fundamentally it cannot do, and what the conversation beyond it would actually look like. One thing before we start, don't change anything you're currently taking based on this video. Talk to your prescribing doctor before adjusting any medication. They're responsible, they know what to do. What I want to do today is give you information to have a better conversation with them. Let's start here, because most patients have been on this drug for years without anyone explaining what it actually does. Gabapentin targets a specific protein in the nervous system. It's called the alpha-2 delta-1 subunit. It's a part of a voltage-gated calcium channel in your nerve cells. When nerves are damaged, they become overreactive. They start firing pain signals when they shouldn't. Part of what drives that overactivity is calcium flooding into the nerve cell, which then releases excitatory chemicals called glutamate. More glutamate means more pain signal. Gabapentin binds to that alpha-2 delta-1 subunit and reduces how much calcium gets in. Less calcium means less glutamate released, which means a quieter pain signal. Think of that as a volume dial on a misfiring nerve. Gabapentin turns the volume down. It doesn't turn the nerve off. It definitely doesn't fix what made the nerve start misfiring in the first place. Here's one more piece that matters. This mechanism only works reliably when that specific protein subunit is overproduced in response to an injury. And how much that subunit is overproduced varies by neuropathy type, by stage, the individual patient. That variation matters, and we'll come back to it in a moment. So to be clear, this is a legitimate medicine. Gabapentin does something real. The question is what it does and what it doesn't do. And that's where most patients haven't gotten the full picture. So why does it stop working? Here's the data that most patients never see. There's a number in clinical pharmacology called the NNT, the number needed to treat. It tells you how many patients have to take a drug at full therapeutic dose before one patient gets at least 50% pain relief. For gabapentin and neuropathic pain, that number is 3 to 8. What that means in plain terms, roughly 3 to 4 out of every 10 patients get meaningful relief from gabapentin at full dose. The other 6 or 7 don't. Most patients never get told this. They were put on the medication, told to increase the dose if it wasn't working, and left to conclude that either the drug wasn't strong enough yet, or that they were somehow failing the treatment. They weren't failing the treatment though. The drug just wasn't matching their mechanism. Remember that alpha-2 delta-1 subunit I mentioned? In some neuropathy types and some stages of the disease, that subunit isn't significantly overproduced when the drug's target isn't sufficiently present. The drug has less leverage to start with. And then there's the side effect ceiling. The therapeutic dose for gabapentin, the dose where it actually controls pain, is often quite high, 1,800 milligrams a day, sometimes up to 3,600. But at that dose, a significant portion of patients are dealing with drowsiness, cognitive fog, dizziness, and unsteadiness. The side effects become the ceiling before the pain control does. So you have 2 problems stacking on each other. A drug that only works for a minority of patients, and a close ceiling driven by side effects for many patients reach before the therapeutic benefit. That's why the close escalation path has so many patients are on run into a wall. Here's the part that I think matters the most, and it's the part that isn't in any package insert. If this is changing how you think about what's been happening to your treatment, hit subscribe. I put out a new video on neuropathy every month, and this topic deserves more than one conversation. I'll link it in the related videos at the end. Gabapentin, again, does not repair nerves. I want to say that clearly because it's the fundamental mismatch in how neuropathy treatment gets framed. A 2025 systemic review published in the Lancet Neurology confirmed what we understood clinically for years. Gabapentinoids, gabapentin and pregabalin, primarily address neuropathic pain symptoms. They are not disease modifying. Here's what that actually means. Gabapentin reduces the pain signal. It does not protect the myelin sheath, the insulation around the nerve, from actually getting damaged. It does not improve blood supply to peripheral nerves. It does not address oxidative stress, the free radical damage that chronically elevated blood sugars on nerve tissue has. It does not correct a B12 deficiency that is actively degrading the myelin sheath. So here's what happens in progressive neuropathy. The underlying cause keeps advancing. The nerve damage keeps accumulating. The pain signal keeps getting louder and louder, and the gabapentin, which is just a volume dial, is sitting in the same position while the signal gets louder and louder underneath it. You chase the dose, you hit the side effect ceiling, and the progression continues regardless. Here's the distinction I want you to take away from this section. Taking gabapentin for neuropathy and treating neuropathy are not the same statement. One is symptom management. That's real, and sometimes it's necessary. The other is disease management, addressing what's driving the nerve damage itself. That's a different conversation, and for most patients, it's a conversation that actually never gets started. So what that other conversation actually looks like, let me give you a framework for what the root cause treatment targets, the things gabapentin doesn't really even touch. The first is oxidative stress. In diabetic neuropathy and in many other metabolic neuropathies, chronically elevated blood sugar generates free radicals that attack the myelin sheath. The nerve insulation literally degrades. Alpha-lipoic acid, ALA as it's called, is one of the most studied compounds for addressing this. That 12-month protocol combining alpha-lipoic acid, B12, superoxide dismutase, and carnitine showed measurable improvement in a nerve conduction velocity and sensory action potential, not just pain scores. That is a very different outcome than just quieting the nerve signal. The second, B12 deficiency. B12 is essential for nerve health repair and the myelin sheath. When B12 is deficient, which is common, especially in patients on metformin or with absorption issues, the myelin continues to degrade. Repleting B12 when deficiency is the driver can reduce symptoms and slow the progression. This is a simple blood test most neuropathy patients haven't had recently. The third is blood sugar and metabolic control. The vascular environment in your peripheral nerves operate in this directly shaped by blood sugar stability. Optimizing HbA1c and reducing blood glucose variability changes the conditions driving the nerve damage, not just the symptoms produced by it. The fourth is vascular insufficiency. Peripheral nerves need adequate blood supply. When the microvascular circulation is compromised, which is common in long-standing diabetic neuropathy, idiopathic neuropathies, the nerves are operating in an ischemic environment. Addressing circulation is part of the root cause equation, and this is important. I'm not saying root cause treatment replaces symptom management. For some patients in acute pain, managing the signal while you're addressing the source is exactly the right approach. The problem isn't that gabapentin exists. The problem is that for most patients, it's the only conversation that ever really happens. So how do you actually start that second conversation? Well, here's what I'd suggest to kind of take you out of this video. If you've been on gabapentin for more than a few months and the relief has leveled off, or if you've been dose escalating without getting ahead of the pain, the question to bring to your provider is this: have we identified what's causing the nerve damage? Not which medication to use for the actual pain, but what's actually driving the underlying nerve injury. The workup I'd want to see essentially in a patient like this is a current B12 level, blood sugar level trend, and HbA1c, inflammatory markers, and if those come back within range, considerations of small fiber neuropathy testing, because that's a form of nerve damage that standard EMG testing won't detect. I did a full video on that, and I'll link it in the end. Don't stop your gabapentin based on this video. I want to be direct about that. Work with your prescribing doctor on any medication decisions, but there's absolutely no reason you can't ask for a root cause workup at the same time. You can manage the symptom and investigate the source at the same time. Most patients aren't being offered that second track, and most of them don't know it's available. Let me leave you with the 3 things I want you to actually remember. 1, only 3 to 4 out of every 10 neuropathy patients gets meaningful pain relief from gabapentin at full therapeutic dose. If it stopped working for you, that's not a personal failure. That is the ceiling of what this drug can do for most people. 2, gabapentin quiets pain signals. It doesn't repair nerves, slow damage progression, or address the oxidative stress, B12 deficiency, or metabolic issues that drive nerve injury. 3, the question beyond gabapentin is what is driving the nerve damage, and is it being properly addressed? That's a conversation most patients never have, and it's one worth really asking. Gabapentin is a legitimate tool. It was designed to manage a signal, not address the source of nerve damage. If it's stopped working for you, you haven't failed anything. You've hit the ceiling of symptom management. The next conversation is about what actually is driving the nerve damage. That's a conversation definitely worth having. If you want to understand why most neuropathy treatments hit the ceiling beyond just gabapentin, I did a full video on that too. I'll link it in here. It connects directly to the framework we have covered today. And if you've ever noticed your symptoms getting gradually worse and you're not sure what to watch for, the 7 signs video that I made is a good next watch. If you have a question about your own situation, or if this video opened up a question about your care, leave it in the comments. I read them. And if you found this useful, subscribe. I keep these videos practical and specific.